Hi, Professor. This is my husband. He's going to be my patient again. This is for the thorax and lung assessment as well as the abdominal assessment. For the purposes of this video, I have my husband standing up so that you can see everything. I couldn't quite rig a situation where he was laying down so we could do the abdominal assessment. But obviously when you're doing an abdominal assessment, you want the patient laying down so they're comfortable. And then for thorax and lung assessment, generally we have them sitting on the edge of the table. So I'm going to go ahead and start. First thing I'm going to be doing is observing his breathing on either side, looking for any obvious retraction of the ribs, anything, any labor, any issues with breathing, and I'm not seeing just the normal rise and fall of his chest, so everything looks okay there. I'm also not seeing any paleness or cyanosis of the skin, any blueness going on, so I also think that he isn't obviously in any respiratory distress. Palpation-wise, I'm just going to be looking at the chest wall, making sure that there's no evidence of any concavity or any obvious convexity either, making sure that everything looks even, that there's no obvious disproportion of the chest wall. And then I'm going to go ahead and palpate for a tactile firmness. So if you can go ahead and say 99 after me.
99, 99, 99, 99, 99, 99.
Perfect. And again, we're looking more for resonance and the consistency of the vibration on both sides. We just want it to sound the same because the vibration of his words are going because there's air in the lungs. Anytime there's any type of fluid or volume in there that we're not looking for, mucus even, it can dull those vibrations. So that's why we inspect for that. This is normally when I also ask them about any type of cough or mucus at night. Have you had anything at night or during the day?
No.
Ask about allergies, issues breathing. A lot of times with asthma, one of the first things they notice is an issue breathing for exercise before anything else, or possibly after being outside if it's allergy induced. So I like to ask a lot of questions, and then of course if they do have a cough, asking if they have dry or wet, what color is the mucus, all those things are really important. And so now I'm going to go ahead and auscultate his lungs, and I start up and I'm going to do the anterior and then the posterior. So you see, I'm going to go ahead and start forward, and then you're going to take a deep breath and then breathe out if you don't mind. Go ahead. Thank you. And of course we're listening, sorry, that's the dogs next door, I don't know if you can hear that. We're listening for any gurgling, wheezing, stridor, anything like that. Any effort basically in breathing that doesn't sound like a clear lung field, so we can notate that in our assessment. If you don't mind turning around for me. So again, I'm going to be looking at, in this case, the posterior. I'm going to be looking, palpating, seeing if there's any obvious deformities, concavity, convexity, anything like that, of the posterior walls, and everything looks fine. I'm going to go ahead and compare his breathing. So I'm going to gather. Okay, now breathe in for me. Perfect. Breathe out. Breathe in. Breathe out. Go ahead. And so there I'm just measuring lung expansion, making sure that everything is in order. You can also measure lung capacity by palpating and percussion by taking a deep breath in. And waiting till you get to the dullness and making a mark. And then having you breathe all the way out. And then holding it. And then starting over. And measuring this field. Normal is 3 to 5, maybe even 6, is what we're looking for normal expansion or for lung capacity. But with athletes, of course, this can be a lot larger. For example, his is a little bit larger because he does a lot of running in baseball. So we need to use his lungs a little bit more. And we're just measuring that for any type of long-term lung disease, looking to see if the capability of holding air has been diminished. So now I'm going to go ahead and listen to the posterior. Go ahead. Breathe in. Breathe out. Breathe in. And I'm going to stay away from the scapula on both sides because that's obviously going to keep me from being able to really hear anything. And I'm just going to have you turn to the side and raise your arm so I can listen here to the lung field. Breathe in. And on the other side, if you don't mind. And here I'm just listening to the middle lobe. It's the best placement for hearing. And then next I'm going to go ahead and of course if you're hearing any sounds, that's when typically you would spend a little bit more time over that area to assess a little bit better. Also asking if they are having breathing issues, if anything makes it worse, making it better. Just really being concerned about ensuring the patient that you are looking at every instance for what could be causing the issue. Okay, I'm going to go ahead and do an abdominal assessment. Again, I'd have the patient lying down at this point. Key factor, of course, is we're going to start with auscultation because after palpating or percussing or anything like that, you can actually make the bowels hyperactive. So we want to avoid that at all costs. We want to be listening. And we're going to listen to all 4 quadrants. And we're listening for 15 to 30 sounds a minute. Generally, after listening for a minute or so, you know the sounds of the bowel. If you aren't hearing anything and you're going to write hypo, you generally need to listen for at least for about 5 minutes. Or if you're going to mark absent whatsoever, again, that whole 5-minute period is important. So I'm going to go ahead and listen. All 4 quadrants. Maybe honestly. Okay. And for him, his bowel sounds were normal in all 4 quadrants, so I would note that. Didn't hear anything hyperactive for bowel sounds, nor were there hypo. It was right around the 15 sounds per minute mark, so he was doing well. Okay, so now I'm going to percuss. So again, I'm just going on the joint here and listening for any dullness and resonance. And then I can percuss over the liver. Just again listening for any dullness. Again, trying to avoid auscultating. And this is generally when I ask questions. I'm going to do a light palpation first. And this is when, especially if they had an abdominal assessment, I would ask about pain. Are you having any pain currently?
No.
I'm going to go ahead and lightly lightly palpate, sorry. Any pain or tenderness when I touch these areas? Right here. No. Okay. And then his rib is here, and I'm going to be asking, so this is where I do my deep palpation. So over here we're looking for the liver and the liver border, so that's what I'm going to be palpating for. Over here I'm going to be looking at the spleen. That should not be palpated, and we shouldn't be able to feel that in this quadrant unless there is something going on, the swelling with the spleen. And then this quadrant, again, is appendix, and we're really not wanting to look for any type of tenderness, as well as the bowel in this area. And then for this area is going to be his colon. So, and sometimes when you're touching the colon, that can be a little not quite painful, but tender for them. So that's to be expected. And sometimes too, after doing deep palpation in general, it just makes the patient pretty uncomfortable. Okay. So I'm just going to be doing... Okay. And so, of course, I would ask him if he had any pain while I was doing that. Okay. And that would be where I would move on to ask him any... You're good. Thank you. And this is where I'd ask about any stomach issues, sometimes I also, generally in this assessment, would ask about bowel movements, if it pertains to it. With women, sometimes it's important to ask about bladder, too, because when you're palpating, especially in the lower quadrant, sometimes if the bladder is super swollen or tender in that area, or that area is inflamed from, say, a UTI, that's when we would bring that up. Another thing that I was taught in nursing school was actually looking and asking about kidneys as well, and that's where you're going to go into the back and percuss, as well as if they are having tenderness, you'll know almost immediately if it's a kidney infection, because pretty much any touch, and if you do the reflex, they will scream in pain. But that wasn't really included in our assessment, so I just wanted to kind of roll that in. Any other questions I normally direct towards the end, and just make sure that I've covered all my bases, history, if they've had their appendix out, if they've had a hernia or any type of surgery. All those things are really important when you're doing these types of assessments. But, well, thank you for listening and hearing my assessment. And sorry again about not being able to observe him laying down. I couldn't quite wig the camera so that you could. Okay, well, thank you.